Hello, good morning, all. Can you hear me? If you can hear me, please, you may want to just wave your hands. Let me be sure I am audible enough. All right, thank you very much, and welcome to today's tele-echo session. We'll be looking at a different thing today, facility case presentation. It's just a way of, learning from our facilities to see how they are able to manage our patients. It's not just telling us the best of the cases you have managed. We're also interested in the ones you want to manage, the ones that you have challenges managing, and perhaps the one you have managed successfully. We just want to see what has happened in between the time of initiation till the time throughout the continuum of care of the patient. And that's what we are going to be looking at today. And we have one of our facilities supported by APIN that will be presenting today. Also, we have a panelist, one of our renowned subject matter experts who is a specialist in this area that will be speaking to us shortly after the facility presentation, just to give further perspective to what has been presented, correct where there's need for corrections, and also, make inputs where necessary. So that's the package we have today. And today we'll be looking at advanced HIV disease. But before we go on, I'd like to encourage all the facilities on the call to please turn on your video and, as usual, send in your attendance using the Zoom platform. We want to see your videos turned. We are very, very interested in all the facilities that join together, for this dynamic section. So again, I want to call on the Federal Ministry of Health to give us an opening remark. And standing by to do that, we have Labake Ikundayo, who is the Senior Population Program Officer at the NASCAP Division of Federal Ministry of Health. Labake, please, can we have you with an opening remark?
Okay, thank you, Prosper. Good morning, everyone. You are welcome to another educative session on ECHO this morning. As Prosper has rightly said, today is facility case presentation, and we have a very important topic, which is advanced HIV diseases. We all know this is meant for clients that are less than 200 copies millimeter cubic per millimeter, and also those clients that are ART naive, and those that have that their treatment are already interrupted and are coming back. And also it's meant for clients that are less than 5-year-olds. This is very important for us to be able to track this particular client, because it usually leads to high rate of mortality. So I will join all our healthcare workers this morning to kindly pay attention to this presentation, for them to be able to pick one thing or the other, in order for them to be able to manage and track things. So on behalf of the Federal Ministry of Health and the leadership of NASCAP, Dr. Adipobola Basharu, I welcome you all this morning and wish us all a successful deliberation this morning. Over to you, Prosper. Thank you.
Thank you very much, Labake. Thanks to the Federal Ministry of Health for all your support. Again, we want to call a representative from U.S. Center for Disease Control, and we have John Essen to do that. John Essen, please, can we have you?
Hi, Prosper. Good morning. Please, can you confirm that you can hear me?
Please, we can hear you. Good morning.
All right. Just a quick one, Prosper. Do we have the folks from the clinical mentors represented on this call today?
Yes, we have. I can see John Ariemu Tunde from the States. So
that's great. That's great. Thanks so much, and good morning, everyone. Once again, it's so good to be on the call today again. I bring you greetings from the CDC leadership and country director, Dr. Mary Boyd. And I also want to thank Vice 3 and Federal Ministry of Health for, anchoring this very interesting sessions, and also to our IPs and facility-based clinical team, following this presentation pattern that is set for this monthly case-based presentation. And also all of our SMEs. I see a couple of them online today. Just want to appreciate you, for providing all the needed support each week, and for being on this call, this very special case-based presentation call today. So today we are our case topic. It's advanced HIV disease, like Dr. Labake has just announced. Yeah, another very interesting topic. This will be presented by APIN's Dr. Yunusa. I think she's the ART coordinator for Ogun State Hospital Ijebu-Ode. Is that correct, Prosper? I think so. Yeah, right. Yeah, Ijebu-Ode. So as we get to hear the facility approach on this subject, so we like to encourage, that the clinical team from other facility participate in the discussion extensively. We feel this is a great way of getting feedback from the health facilities on case and treatment of our patients' management approach that will ultimately, enhance knowledge. So again, thank you everyone for being on this call today. We're looking forward to a very wonderful deliberation. And until then, we talk to you again later. Thank you, and over.
Thank you very much, John, for that goodwill message from CDC, our founders. Thank you very much. So today, we'll be looking at advanced HIV disease, and that will be taken by Dr. Idayat Yunusa, and she is ART coordinator for State Hospital Ijebu-Ode in Ogun State. And we'll have Professor Suleiman Akamu. He is a hematology and a transfusion medicine at College of Medicine, University of Lagos, and also a consultant hematologist at Lagos University Hospital. He currently chairs the National Task Team on Antiretroviral Therapy in Nigeria, and we are privileged to have him to talk to you shortly after the presentation. Prof, you are welcome. So now, Dr. Idayat, can we have you share your slides and let's see what APIN has for us. Dr. Idayat, over to you.
Good morning, sirs and ma'ams. Today, I'll be taking slide presentation on advanced HIV disease, using one of our clients as the case study. I am Idayat Oladunni Yunusa, the ART coordinator and the site clinician for State Hospital Ijebu-Ode. I'll be doing that under the following outlines. The facility profile, introduction to AHD, the case presentation, investigation, length, recommendation. State Hospital Ijebu-Ode is a secondary facility located in Ijebu-Ode local government area of Ogun State. According to the 2022 area population estimate, the local area has a population estimate of 368,000 persons. It is the only comprehensive ART facility in the local government. A host of services are rendered at the ART clinic, which include the HIV testing services, prevention of mother-to-child transmission services, adult ART services, pediatric ART services, pre-exposure prophylaxis services, post-exposure services, pharmacy services, the differentiated service delivery models, laboratory services, and Operation 000 services for the Hospital in Ijebu-Ode has a 224-bed capacity for inpatient care. So at the 30th of June, the facility has a treatment current of 3,192. Advanced HD. HIV disease, that's AHD, according to WHO, is defined as follows. In adults, adolescents, and children older than 5 years, a CD4 count of less than 200 cells per mm³, or WHO clinical stage 3 of 4 events will be regarded as AHD. However, in children younger than 5 years of age who are HIV positive are considered to have AHD irrespective of their CD4 count or the CD4 persons. People with high risk of death even after starting ART. This risk increases with decreasing CD4 counts. The most common causes of severe illness and death includes tuberculosis, critical meningitis, and severe bacterial infections. These infections account significantly for morbidity and mortality in the AHD population. The appearance of opportunistic infections is directly related to the extent of immune deficiency. That is, the lower the CD4 counts, the higher the likelihood of appearance of opportunistic infections. So our case study this morning, Mrs. AM is a 43-year-old clergywoman who resides in Ijebu-Ode area of Ogun State. She presented to our HIV testing service on the 20th April 2022, after being referred from a private clinic from where she has just been discharged. She was retested and confirmed to be positive to HIV and was thus enrolled the same day. Mrs. AM is married with children who are all HIV negative and to a husband who is also HIV negative. At presentation, she had weight loss of 6 months duration, resolving fever of 3 weeks duration, resolving vomiting of 3 weeks duration, resolving diarrhea of 2 weeks duration. She weighed 68 kg and had a blood pressure of 115/77 millimeter of mercury. Examination revealed a middle-aged woman, ill-looking, not pale, not in any respiratory distress, mildly dehydrated, afebrile, anecteric. She had oral thrush, but she could swallow without pain. She had no pedal edema. Her baseline investigations are as follows. A CD4 cell count of 6 cells per mm³. First, she had a TB lamb, which came out to be positive, a serum crab, which came out to be negative, hepatitis B was negative, hepatitis C was negative. She had a gene expert, which came out to be negative. Her urinalysis was also negative for protein and glucose. She was thus assessed to be of WHO clinical stage 3. At that visit, she was given contromoxazole for 2 weeks, as well as nystatin oral drops for her oral thrush. She received nutritional counseling from our counselors, and emphasis was on liberal fluid and fruits intake. She was immediately referred to DOTS units for her and with the positive TBLF lamb results, which was commenced the following day with her husband as her treatment partner. The husband was counseled afterwards and given tenofovir lamivudine as PrEP due to his own HIV status. She was followed up with phone calls at strategic intervals, as was discussed with her at her baseline visits. She continued her daily anti-TB medications and other OI medications till she was reviewed the second visit. On her second visit, which was on the 11th of May 2022, she was commenced on antiretrovirals of tenofovir lamivudine dolutegravir, 300-350 milligram fixed dose, as well as additional single dose dolutegravir 50 milligram, making a total of DTG 100 milligram with a weight of 69 kg. At that visit, her thrush had cleared, and she was given cotrimoxazole prophylactic dose of 60 milligram. At her third visit on the 3rd of August, she weighed 72 kg. Her blood pressure was 138/96 millimeter of mercury. She was very, she had a good adherence on her anti-TB medication. She was also counseled on the need to closely monitor her blood pressure and on some lifestyle modification. At her 4th visit on the 26th of October, she had completed 6 months of anti-TB medication. She was given 10,400 dolutegravir without additional DTG. Her weight was 75 kg, and she had a viral load done on the same day, which eventually came out to be less than 20 copies per ml. Management of advanced HIV disease with the introduction of urine TB-LF lamb, people with CB cells per mmK, has contributed immensely to detecting TB-HIV co-infection. In this case, she would have been regarded as being TB negative with her negative gene experts. Also, regular phone call monitoring by the CMT trackers and TB point of care person, alongside the support she enjoyed from her treatment partner, who is also contributed significantly to her having a good adherence with the dual therapy. Recommendation: early disclosure and treatment support should be encouraged. Screening for TB in the absence of cough should be practiced. Consistent supply of TB lamb kits should be ensured. AFD remains one of the leading causes of morbidity and mortality in HIV-infected clients due to the tuberculosis, cryptococcal meningitis, and severe bacterial infections, as we have earlier mentioned. The of TB lamb rapid kits have contributed to the reduction of mortality in TB-HIV co-infected clients due to its detection and prompt treatment. Thank you for the opportunity given to me.
You're welcome for accepting the opportunity given to you. Thank you very much, Dr. Yinisa. You may want to stop sharing your screen now, except our prof request to see a particular slide, then you can just put it up again. So thank you very much, and we want to appreciate APIN and APIN team that made this possible for your presentation. So I said you may want to stop sharing your screen, Dr. Yinisa. So we have our subject matter expert on the call who would want to, give his perspective to this, and then let also x-ray and see where you did the best and where there is need for correction. So I want to call on Professor Suleiman Akamu. Prof, please, you may want to come in now.
Thank you, and good morning, everyone. First of all, kudos to Idaya. Our presentation was very lucid. We heard you very clearly, except in some areas where your internet appears to be fluctuating, but that presentation was clear enough. couple of issues that I would like to briefly comment on this case presentation. And number one is the clinical staging of this, your patient that you think has a clinical stage 3 disease. I'm thinking that the fact that she had oral thrush and the fact that you emphasized that she was able to swallow well was the basis of your clinical stage 3 disease in this individual, because you imply by that emphasis that this person does not have esophageal candidiasis. Oral candidiasis we put at clinical stage 3, but if he had events in the esophagus downward, that would have pushed her to clinical stage 4. However, this individual, you screened for pulmonary tuberculosis, was negative by a gene expert. It means that this individual doesn't have pulmonary TB. But the TB lamp, urine TB lamp was positive. So the TB that this individual has cannot be pulmonary tuberculosis. It has to be TB elsewhere. And TB elsewhere in the body, not in the lung, is referred to as extra pulmonary tuberculosis. An HIV-infected person with a diagnosis of extrapulmonary tuberculosis will not be clinical stage 3. This individual will be clinical stage 4 disease. I want us to get that clear. And this is one of the great benefits that you also emphasize in your presentation, the usefulness of the urine TB lamp in making a diagnosis of TB, because several people who have either undiagnosed extrapulmonary TB, when they are very severely immunocompromised, like this, your patient, urine TB lamp will give them out and you'll be able to appropriately diagnose them. The TB that you have treated, we do not know. Perhaps if we had the luxury of doing what you can call a CT scan, you could have seen maybe it has a disease, a port disease somewhere that symptom was not very significantly pronounced. I mean, the TB disease of the bone somewhere. Could have a TB in the ovary, could have a TB in the uterus, could have TB anywhere. If you had had TB in one of the lymph nodes, that could have also been seen as a lymphadenopathy that is going to give what they call cold abscess. But I didn't see this. The fact that urine TB lamp was positive is a significant finding in this individual and push this woman to clinical stage 4 disease. Let's quickly also share something about how relevant or the science behind the so-called simple urine TB lamp test. An individual will not, that is TB infected, will not be urine TB lamp positive if that individual is not severely immunocompromised. Majority of people who are TB infected and have CD4 cell count 150, 200, 300, and they are TB infected, urine TB lamp will be negative. Urine TB lamp tend to be positive only when you have severe immunosuppression, the type that your patient has. And what brings this about is the fact that the God-given immunity against TB resides in the macrophages. the macrophages tend to set up what we call a granulomatous lesion around a granulomatous lesion that help us to mop up the microtubercular organisms. That granuloma, if you see the histology of the granuloma under the microscope, if you see the histology that is shown to you, you will see that at the center of that granuloma will be the macrophages that have engulfed the microtubercular organisms. Surrounding the macrophages, you will see a ring of T cells. Those T cells tend to be CD4 positive T cells, CD8 T cells. These T cells exist around the macrophages to support the macrophages to be able to handle and deliver cytolytic kill on the microtubercular organisms they have engulfed. What we mean here is that in the presence of the T cell, particularly the CD4 positive T cell, this T cell tends to release what we call gamma interferon. And gamma interferon that is released helps to stimulate the macrophages to be able to produce all the cytolytic proteins that they require to be able to deliver cytolytic kill on the macrophages they engulf. When you have gross deficiency of the T cell, you probably will not be able to generate sufficient amount of gamma interferon, and capacity of the macrophages to kill microtubercular organism will be lost. So you will have C of this organism within the macrophages that are supposed to be killing them. They will just be replicating. As they are replicating their cell wall material. And those cell wall material are spilled into the blood. From the blood, they are spilled into the urine. So it is only in situations where you have severe immunodeficiency that you are able to see microtuberculous organism multiplying. So you have correctly used the urine TB lab. You have made the diagnosis, but your clinical staging, if I was in your center, I would have put that woman at clinical stage 4. And I think you should restage her to have clinical stage 4 disease going forward. Because when you're going to review her in the future, will be some of your patients that had clinical stage 4 disease. That's one. Number 2, a comment on the CD4 cell count that is 6 per millimeter cube. That is extreme immunosuppression. And my belief is that this individual had waited for too long, allowed so much time for the viruses to eliminate CD4 positive cell count. I think he must have lived fairly very well. He must have maybe perhaps with somebody I didn't hear about her social status, social class status. Yeah, maybe somebody that is actually living very well. Where the teaching point here is that sometimes it is possible that you are severely immunocompromised and you are still able to live very well. You will not have symptoms that is going to make you to present to the hospital on time. This person must have lived with CD4 cell count 200, 180, 100, and it's not coming to detection. So he has a good living. He must be a highly placed person that eats well. These type of people, we say, they have immunological aids, but do not have clinical aids. So he must have lived with immunological aids for a long time before all of a sudden the antigen load he has broke her down and make her to present to wherever I presented to before she was sent to your hospital. The number 3 point I want to comment on here, I hear that the husband is HIV negative. That's fantastic, and it's a good thing. But it's also a teaching point that we should know that this disease appears to be gender bias. If the man were to be the one that is infected, this woman will have collected the virus from her. And this man had lived with somebody that is severely immunocompromised and must have had heavy viremia. And this man did not become HIV infected by her. We say that HIV is rarely transmitted on marriage bed to men, but it's easily transmitted on marriage bed to women. And that is very important for us to understand. I want to emphasize this from the point of view of men who, when their wives are positive and they are negative, they tend to abandon their wives. And if they have not legally married, they find excuse not to continue with the relationship. But women don't do so. Women who are negative and they are going to continue to have relationship with a man that is positive, they don't run away. And they are at higher risk. It's like who is supposed to be running away from one another? The woman that is HIV negative is the one that is supposed to be running away from the man that is negative, that is positive, because she has a very high likelihood of collecting the virus. But the man that is HIV negative has a very low likelihood, particularly if it's a marriage on the, if the sex that is on the marriage bed, not a sex in the offices, not casual sex. We say a man that is going to become HIV infected by having sex with HIV positive woman is a man that is having casual sex or is having that sex with an unwilling woman. I guess to your office and you must just get inside her and she's not willing, her mind is not there. She did not produce what we call sex hormone. She's not wet. You get bruised while you are having the thing. She's infected, you will get it. But the same thing is not true for the woman. Majority of women, 80% of women have what we call cofactors of infection. They tend to have vaginitis. They tend to have microscopic ulcerations on the surface of the cervix. The young girl in particular has a zone of cell that is in between this uterus and the cervix. They call zona pellucida cell. That cell easily catches HIV when HIV-infected sperm get deposited in the vagina. So the woman is at a higher risk. So I'm not surprised that this man tested HIV negative, but it is fantastic that you also started this individual on PrEP. That was a very good thing that you did. So in summary, I think by and large, this was a very good presentation, my sister. I'm not sure whether I hear you screen for other things. Okay, I think you said so. You screened for cryptococcal meningitis. She was negative with crack. There are 5 major killer diseases that an individual that is severely immunocompromised like this should be screened for. You did screen for TB and you got it. You screened for cryptococcal meningitis. I think that was reported to be negative. The other 3, I think you just mentioned them. Now the cerebral toxoplasmosis is always hiding somewhere there. For next time when you see this type of patient, we should screen. this severely immunocompromised individual for cerebral toxicity. It's the third major killer of an individual that is sick that this severely immunocompromised. And you should just send for Toxoplasma gondii antibody IgG, IgM in the minimum. And again, I think you can do that. You screen, okay. You should also screen. I'm happy. You said that she has no respiratory illness, but we should always have at the back of our mind, majority of our patients can also have pneumocystis jirovecii pneumonia. But one of your clinical findings is that the respiratory functions was quite good. And of course, I think you emphasize bacterial sepsis. Whether you collected blood and screened for septicemia, I didn't get to hear that, whether you did that or didn't do it. But by and large, you have succeeded in bringing this woman back to life. I didn't hear what was her latest CD4 second, but I hear that viral load as at the time that she came back is 20. That was great. I want to believe that you have stopped the anti-TB regimen after the 6 months of, please, I'm not so sure whether that is the right thing to do for this individual, because I think the 6 months therapy is for pulmonary tuberculosis. When you make a diagnosis of extrapulmonary tuberculosis, I guess the minimum treatment period should be 9 months. And some people will even say 12 months. In the past, it used to be 18 months, particularly if it's a TB of the bone, because that one doesn't get cleared, on time. So I thank you for asking me to come and review this presentation. Prosper, over to you.
Thank you very much, Prof, for this well-elaborated feedback. I have my question that I want to ask, and then I also have some that's I think on the chat box. So please, the floor is open for questions regarding this. But while we wait for questions, Prof, I'd like to ask you made mention that HIV is rarely transferred from married women to men, and then why it is common to be transferred from married men to women. Please, I'd like you to elaborate on that, just for clarity.
Okay. The point we are raising here is that for a man to catch HIV from from having sex with HIV-infected woman, there is a basic, not a mandatory requirement that this man must suffer a bruise or a wound on the surface of the penis during the sexual act. There's a need for that, because the HIV-contaminated vagina and cervical secretions, there's no force in the vagina that can propel vaginal secretions and push it into the male urethral opening. It doesn't happen. It is the surface of the penis that interact with vaginal secretions that can become the portal of entry of the virus. And if there is no wound on the surface of the penis, that man will not become HIV infected. So it is only a situation that this man has sex with an unwilling woman, and he happens to suffer an injury or a bruise during the sex, that the man will become HIV infected. However, the reverse is not true for the woman, because the man is propelling HIV-contaminated semen into her vagina. And 80% of women have cofactors of infection. Number one cofactor of infection is that they tend to have what we call vaginitis, and may not be symptomatic. They may have mild cervicitis, microscopic ulcerations on the surface of the cervix that is not symptomatic. And those microscopic observations are waiting to collect the virus when HIV-infected sperm is deposited in the vagina. This is how elderly women can become HIV-infected when they have sex. For the young girls, the problem is more, in the sense that the young girls, or the teenagers in particular, many of them don't produce secretions when they have sex. It is called, the sex hormone is supposed to stimulate the cervix, the vagina glands, and produce a lot of secretions. And those secretions that is produced during sex, it may actually make sex enjoyable, number one, but it has more function than that. If an HIV-infected sperm gets deposited and the woman is able to produce large quantity of vaginal secretion, those secretions are known to have virucidal effect. They wrap up the virus, cascade the virus, and make the virus uninfectious. Most adult women are able to do that. And that is why adult women are even more protected than the younger girls who have anovulatory cycles and rarely produce sex hormone when they have sex. The other problem with the younger girls is that, unlike the adult vagina, that is multi-layered. The vaginal lining of the younger girls is very, very similar to the anal lining, the lining of the anus, because it's monolayer and it's easily susceptible to tearing. And when they have sex with elderly men, they can easily have tear and then get HIV-infected sperm directly inserted into the vaginal wall, and they easily become infected. These are some of the reasons why we say the younger girl, the majority of women who are testing positive at age 22, 23, 20, majority have become infected at age 15, 16, 17, when they had such sex, when they have sexual debut with, unfortunately for them, with women and with men that are HIV infected. I hope that's partly clear your mind.
Yes,
Prosper.
thank you very much, Prof. This is well detailed. Thank you very much. And I hope it also benefited our audience and then the facility folks out there. So we have a couple of questions, and I'm going to be taking them one by one. Please, we give priority to those who raise their hands. I still would check the chat box, but please, for seamless selection, kindly use the Zoom platform to raise your hands. So we have Dr. Michael Onila. Please, we're already going out of time, so you may want to just go quickly straight to your questions. Dr. Michael.
Thank you. Thank you very much, Prof. My question is that, assuming this particular client is CRAG positive, and then maybe they do the CSF by lumbar puncture, and it turns out to be positive, what is the approach to management of this kind of patient? TB, LAM reactive, CRAG positive, which one do we start first? Is it the treatment for the TB or for the cryptococcal meningitis? Thank you.
All right, thank you very much. Prof, can I beg that you take note of, this question, let me at least have 4 or 3, and then you respond, then we'll come back and take the remaining one. Is that okay by you, Prof?
Go ahead.
All right. Again, I'm calling Aremu John Tunde, clinical mentor, Gombe State. Please, can we have you straight to the question?
All right, thank you very much, Dr. Idayat, for the wonderful presentation. As Prof said, thank God that the patient became undetectable at the end of 6 months. However, I just felt that I should highlight some things. You said after commencement of treatment, you followed up the patient with strategic communication, communication at strategic intervals. I don't understand what you mean by that strategic intervals. For the benefit of your program, I think you should have a program direction in which you communicate to the patient and not at the discretion of the person that is making the communication. Just further addition with what Prof said about the TB. For the present guideline, the TB of the bone and TB of the CNS naturally will take more time, 12 months to treat. So even for a patient that have a CD4 count of that, I think in your examination, you should particularly look for TB of the meninges, and you should be able to capture it. That despite the fact that CRAG is negative, you should be able to say whether there is any form of meningeal signs or to see whether there's any form of bone involvement by looking at the tenderness at the spine. I think that will give you a lot of leverage to know the duration of time you are going to administer your anti-TB. And I didn't get properly the duration of time in which you started your anti-TB and antiretroviral therapy. Probably I missed it, but I hope that the anti-TB was started first before your antiretroviral. But all in all, I think it was a wonderful presentation. Well done for saving another life. Thank you very much, Alova.
Thank you, Dr. Arimu Tunde. Let's have Patrick. Patrick Guest, can we have you ask your question?
Okay. Thank you very much for the presentation, particularly for Prof's explanation. I just want to ask a question on issue of discordancy. Now, from what I know before today is that we have some CD4 receptors, like the CCR5 receptor and the CXCR4 receptors. Now, those receptors, in fact, there is one HIV drug, like the Miravirog, that blocks, that is just it's actually an antagonist of CCR5 receptor. So my question is that I was told that maybe through reading and then maybe through some of the people that have gone ahead of us, that some group of people don't have these receptors. So that once you don't have these receptors, there is that possibility that you might not get HIV infection. So I don't know how true it is. Can maybe Prof give an insight for that? Thank you.
All right, thank you very much. We still have 4 hands up. We'll get back to you shortly. Sorry, now 5. Prof, if you would take a few minutes to respond to this, and then we'll take the remaining question. Thank you, Prof. Over to you.
So I think the first question is co-management, the comorbidities of critical meningitis, TB, and HIV. You can also add more, including pneumocystis, pneumonia, because this can actually happen together in a severely immunocompromised individual. This is one clear indication of polypharmacy that you have to do if that patient is going to survive. You will manage critical. TB is as important as critical meningitis, and you are treating one, the other one is killing. You will treat them together. The likelihood of complications or toxicity of the drugs is there, but what we are going to gain if we are able to so we have to just straight to the point. You treat all of them together. Don't let's waste time on that. Now, this other question that is talking about the fusion proteins. When HIV is going to get into we say there are infectable and non-infectable cells. For HIV to infect a cell, primarily that cell must have CD4 molecule on it. Glycoprotein 120 of the virus recognizes CD4 molecule as a receptor on the membrane of of the cells that have CD4 molecule. So CD4 molecule helps to anchor the virus on the membrane of the infectable cell. But that anchorage does not translate into movement of the virus into the cytoplasm of the infectable cell. When the virus is anchored, for that virus to gain access into the cytoplasm of infectable cell, there must be a fusion of the membrane of the virus with the membrane of the human cell, where the two membranes becomes unified, and the content of the inner content of the virus is emptied into the cytoplasm of the infectable cell. So you have what we call the fusion protein on the membrane of the virus, and you also have the fusion protein on the membrane of the infectable cell. But the virus must be anchored first before the fusion protein fuse with one another. The fusion protein on the membrane of the virus is glycoprotein 41, and then the fusion protein on the membrane of the human cell are the protein I've just mentioned, CCR5, CRX4, and CCR2, and a few other chemical receptors that have been identified. These are what they call the fusion proteins. And indeed, 1.5 to 2% of population of Europe, and clearly 1.5% of population in the United States have mutation of the chemical receptor or the fusion genes on the membrane of the cell. So this 1.5% of population in Europe and America can never be HIV, they cannot become HIV infected. The virus can get anchored on the membrane of the CD4 cell, but they will never be able to enter into the cytoplasm of the infectable cell. And this is actually the logic of cure that has been pronounced for at least 5 patients. Of the several millions of people that are living with HIV today, only 5 absolute cure have been found. And this cure is coming from stem cell transplantation, when individuals who have delta 32 deletion of the CCR5 gene were used as the stem cell donor for an HIV-infected person who has an indication for stem cell transplantation. That's what happened for the so-called Berlin patient. That's what happened for the so-called London patient. That's what happened for the so-called city of something patient. There are about 5 of them that had this type of transplantation, and they use for them donors that have the 32 deletion of the chemical receptor 5. So if you have an individual that has a deletion of CCR5 protein, that individual can never become HIV infected. And if you use that person as a donor for an HIV infected person, and the graph states the donor and the recipient with HIV infected will also be cured of HIV, because we will not be able to transmit the virus to the cells again. This has been demonstrated at least in 5 individuals. I think yesterday at Brisbane, in the bit that is still ongoing, the ISM that is still ongoing, the 6th patient has also been declared cured. But this 6th patient is unlike the other 5 patients that received the 32 deletion of CCR5 gene. This one didn't receive the 32 deletions. So the mechanism of the care of the 6th patient as a result of stem cell transplantation is still being worked out. It is being proposed that what they call graft versus host disease must have helped this, what they call Jennifer. This is the 6th patient, they call it Jennifer patient. He received stem cell transplantation, has also been declared cured. So this will explain. Well, let me also quickly tell you that a number of sex workers in most big cities in Africa have been screened for delta 32 deletion. We have not documented one in Africa. So I have not documented, we have never done one in Nigeria to see whether we have a population, what proportion of our population have delta 32 deletion that can be seen there. They will be HIV unaffectable. They did this study in Kenya, they did in Zimbabwe, they did in South Africa, looking for delta 32 deleted Africans. We have not found a single one. I think the one they found in Kenya was deletion of CCR or mutation of CCR2, which is not a very, very prominent fusion protein, unlike the CCR5 and the CXR4, proteins. So, and for those, and they found that actually in some sex workers in Kenya, it may be the reason why some of those sex workers who have been having regular sex with white customers that are known to be HIV infected and did not become HIV infectable. So maybe it's because they have the CCR2, but the CCR5, CSR4 is there to be documented anywhere on the soil of Africa. Maybe if you have money, somebody can help us to also look at what our population have, because we have not documented it in Nigeria, whether we have or we don't have. But that it's not found in some other parts of Africa may mean that we may also not find it here.
Thank you. Thank you very much, Prof. For salvation of time, I just would want to read out one question and then give other ones to ask, and then I will just have you respond to them quickly. So this one is from Dr. Chioma. He said, please, what are the 5 killer diseases in severely immunocompromised patients? Please, what are the 5 killer diseases in severely immunocompromised patients? Then I get back to the questions. Please, you have 30 seconds to ask your question. Just spare us the initial commendation and all. Let's have Ijebu-Ode Afantan. Please, can you ask your question straight? Ijebu-Ode Afantan.
Okay, so my question is, in a situation whereby a newly diagnosed patient is transfused of blood before the CD4 count is taken, can it influence the CD4 count? Thank you.
All right, thank you very much.
The next question is, now in a situation where we have been treating people with TB positive for 6 months on TB drugs, is it now ideal for us to extend it to 9 months? Or there are other investigations that need to decide whether they should take up to 9 months or not, or extend even to the 12 months? Thank you, sir. Over.
Thank you very much. And then we'll have IHB and Josiah John. Can you quickly ask your question? IHB and Josiah John in 30 seconds.
Good morning, sir. My question is the same. The second question that was asked, that is the same question I was asking.
All right, thank you. Then let's have Omega Ann quickly ask your question. Omega Ann, are you there? Can you ask your question? All right, Omega Ann is not here.
Good morning, sir.
Who is
Good morning, sir. My name is Ann Omega.
Okay,
my question, can you hear me?
I can hear you. What's your question?
My question is, in a situation whereby we have been using TB drug to treat pleural effusion and the patients are still coming down, I don't know, would they still continue the treatment, and the pleural effusion treatment is just for 6 months? Can they still continue the treatment with the TB drugs? Thank you, sir.
All right, thank you. Dr. Idiat, your hand is up. Do you want to make comment before Prof round off and then we'll leave? Your hand has been up, Dr. Idiat. Or is it an old hand?
Yes, sir. Yes, sir.
A quick one, please.
Just a quick one. Anti-TB was commenced 18 days after, 8 days before initiation of ARV in this instance. No palpable lymph node enlargement, no bony observation or spine anomaly for that patient. However, my question is, does the guideline allow us to use CD4 to monitor those who are severely immunocompromised? Perhaps, let's say, people with CD4 counts of less than 50. Then this, okay, that's fine. Thank you.
All right, thank you very much. I hope you know your questions are not exhaustive. You can also reach me or reach directly to Prof, and further guidance will be provided to you. Prof, please, I don't know how, for salvation of time, if you can use just a few minutes to respond to this, and then we'll be out of here. Over to you, Prof.
Thank you very much. The killer diseases, the 5 of them. Number 1, tuberculosis. Number 2, cryptococcal meningitis. Number 3, cerebral toxoplasmosis. Number 4, pneumocystis jirovecii pneumonia. And number 5, bacterial sepsis or septicemia. Those are the 5 killer diseases that take away people with advanced HIV disease. Now, CD4 cell count following blood transfusion, whether it's going to significantly affect, it may, but it will not be very significant. It may, but it will not be very significant. You have, depending on the volume of blood that is transfused, and also depend, because the lymphocyte that you have in the blood bag are still there, they will be counted. But the truth of the matter is that if that blood that you are transfusing is not fresh blood, if that stayed in the blood bank for more than 24 hours, the CD4 molecule is thermolabile and it gets biodegraded in storage. Several studies have shown us that if you collect your EDTA blood samples today, and you are doing the CD4 cell count tomorrow, we have documented that the value that you are going to get will be significantly different from the value you ought to have gotten if you have done it that same day. So you do not collect blood for CD4 cell count and store it overnight and think you are going to get the same result. The molecule that you are looking for on the membrane of those cells are biodegradable and you don't get it. So if it is coming from the blood bag and that blood bag is taken as fresh blood and transfused, it may slightly increase your CD4 cell count of the patient if the donor blood is very rich in CD4 positive cell. However, if that blood has been stored for 24 hours, most of the blood stored for 48 hours and so before you are practically not going to add any significant CD4 cell to the patient or to the recipient count. Now, treatment of TB LAM positives when they are gene expert negative. The truth of the matter is that if this individual are TB LAM positive, they are very likely to have extrapulmonary TB. And that is related to one last question somewhere there, treatment of TB LAM positive individual. I think when TB LAM is positive, we should try as much as possible to exclude extrapulmonary TB. Majority of people that have pulmonary tuberculosis, they will present with symptoms. Expert thing will be positive. And you can always say, well, this is pulmonary tuberculosis, and you move on. So, but when it is TB LAM, that's why we say urine TB LAM is helping us greatly to close the gap in TB diagnosis. Because those that you may not have been able to diagnose, your urine TB LAM is helping, and majority of them will have extrapulmonary TB. Now, your patient is having pleural effusion, and he has been treated for more than 6 months, whether you should continue to treat. Please remember, there are differential diagnosis to TB. They will say, oh, smear negative TB. There's no like smear negative TB. If TB is there, TB is there. So there are a number of other disease conditions that you should exclude. Maybe you should also get a sample of your effusion fluid and send for some tests for you to be able to exclude. You may have fungal illnesses. Histoplasma disease can be there. Several fungal illnesses actually mimic TB, and you may be having this problem. Or you may also screen that individual for resistant TB. Not just continue to treat TB. For 6 months, it's not responding, something else has to be done. Please, that patient need further investigation. Do you want to monitor a patient with CD4 cell count? Left to me, yes, but left to your program, no. Your program said, oh, but the program allows us to do initial CD4 to diagnose patient whether they are AHD or they are not AHD. As far as I'm concerned, it would be very nice thing to tell my patient, you came in with 6 and now your CD4 cell count is going up. Can you see what you have done? You shouldn't have allowed this to come down. So it's a good clinical practice. It benefits you, benefits the patient. But when your program said you don't have money to do it, it's a pity, but it's the right thing to do.
Thank you very much, Prof. Thank you very much, Prof, for the wonderful response. And then we are almost out of time. We have spent extra 10 minutes. Apologies to that. We want to call on the CDC. Do you have final word from us? John, are you still there? John, are you still there?
Can you hear me? Good morning again.
Yeah, I can hear you.
Yeah. All right. Yeah. Thanks so much, Prosper. It was a very wonderful session today. I hardly stepped, take my ears out of it, for a second, because it was a loaded one. Thanks so much, Dr. Ide, for the wonderful presentation that you made earlier, and Professor Atamu. I appreciate your insights, very extensive insight and guidance on this presentation today. It was a great one, and I urge people that missed this session to go back and listen to this recording again. And I think it's a great lesson that we all took note of, and it's a lot of discussion that went on here today, and a lot to learn from. So thank you everyone for joining this session today, Prosper. I will look forward to seeing the slides distributed to people, and then the link so people can do a follow through learning on this. Have a good day, everyone, and see you next week.
Thank you very much. Can we have a closing remark from Labake, Federal Ministry of Health? Labake, are you there?
Yeah, thank you. So I would first of all like to appreciate yes, can you hear?
Labake, I'm afraid your network is very bad. We haven't had time to hear you. So on behalf of Federal Ministry of Health, Phase 3, and all other persons on the call, I want to say thank you very much, and we look forward to having you again next week. We'll be looking at another interesting one. So thank you very much today, and please sorry for taking much of your time. A big thanks to Dr. Ide, UNISA, and the APIN team that made this happen. We want to say thank you very much and keep the good work going. Bye for now.